Welcome to This Explainer. Today, we're tackling a massive neurological emergency, the ischemic stroke. We're going to frame the most high-yield, critical clinical data you'll ever encounter for what it truly is, an absolute race against the clock to save brain tissue. Because when a stroke hits, preparation and rapid recall, those are your absolute best weapons. Let's get right into it.
A patient suddenly loses speech, weakness on one side. Every second, neurons are dying. Just let that reality sink in for a second. Recognizing this terrifying immediate loss of function is literally the first crucial step in saving a patient's life. In the ER, hesitation just isn't an option. We have to know exactly what we're looking at right away. And that brings us to the big picture. A whopping 85% of all stroke cases you'll see in practice are ischemic. While hemorrhagic strokes are obviously critical, the vast majority of the time, you're dealing with a blockage. So mastering this ischemic pathway, that basically means you're mastering the lion's share of stroke medicine.
Here's our strict roadmap for today to make sure you lock down this protocol. We've got time is brain, types and brain territories, recognizing symptoms fast, the golden rule of CT first, the treatment time window, and a high-yield rapid review.
All right, Section 1, time is brain, the definition of an emergency.
So, an ischemic stroke is defined as the loss of brain function due to reduced blood supply, leading to infarction. Reduced blood flow directly equals dead neurons. This isn't just a temporary pause. It's a rapid, totally unforgiving cascade to tissue death. Actually, think about this. For every single minute a large vessel blockage is left untreated, roughly 2 million neurons are lost forever. 2 million! That countdown begins the absolute second symptoms appear.
Moving on to Section 2, types and brain territories tracing the blockage.
We can cleanly map the 3 distinct stroke mechanisms right to their primary culprits, and honestly, this is absolute gold for exams and patient history. First up, we have thrombotic strokes. These are caused by atherosclerosis, plaque buildup right there in the cerebral vessels. This one is the most common overall. Second are embolic strokes, which travel from elsewhere, usually from the heart, so always think of atrial fibrillation throwing a clot. And third, lacunar strokes. These are those deep, small vessel blockages overwhelmingly linked to long-standing hypertension.
To nail the clinical presentation, you've got to memorize these 3 territories. If a patient comes in with contralateral hemiparesis, where the face and arm are way more affected than the leg, plus aphasia, boom, that's a middle cerebral artery, or MCA stroke. It's the most commonly affected artery, hands down. Contrast that with the anterior cerebral artery, the ACA, where the leg weakness is actually greater than the arm weakness. And finally, the posterior cerebral artery, or PCA. This controls the back of the brain, so blockages here mostly show up as visual deficits. Specifically, homonymous hemionia. That's where the patient loses half their visual field in both eyes. Okay, Section 3, recognizing symptoms fast, risk factors and immediate signs. Long before the alarm bells ring, patients are usually battling some major underlying risks. Hypertension is the absolute heavy hitter here. It damages the vessels and perfectly sets the stage for both large atherosclerosis and those small lacunar infarcts we just talked about. Atrial fibrillation is another huge one, total MCQ gold, by the way, alongside diabetes, smoking, and dyslipidemia. Keeping these in check is exactly how we stop the stroke before it even starts. And that brings us to the famous FAST mnemonic. It's a rapid-fire screening tool used everywhere, and for good reason. It basically takes complex neurology and boils it down into a super clear, immediate call to action. We're looking at face drooping, arm weakness, and speech difficulty, which means it is time to act. You see any of these? The emergency protocol is officially triggered. No questions asked. Which leads into Section 4, the golden rule. CT first. A non-contrast CT scan of the head is your absolute first move. Period. Now, you might be thinking, well, hold on, isn't an MRI way more detailed? And yes, you're totally right. An MRI with diffusion-weighted imaging is incredibly sensitive to acute ischemia. But here's the catch. An MRI just takes too long. A non-contrast CT is blazing fast. And here's the kicker. Its primary job isn't even necessarily to spot the ischemic stroke right away. In fact, an early CT might look completely normal. Its true, absolute mandatory job is to quickly rule out a hemorrhage. We have to be 100% sure the brain isn't actively bleeding before we even think about pushing powerful blood thinners. Moving on to Section 5, the treatment time window, the narrow margin for survival. 4.5. That is the magic number. You have exactly 4.5 hours from the onset of symptoms to administer intravenous TPA, or alteplase. This is the systemic clot-busting drug that can literally dissolve the blockage and reverse the ischemia. It's a real game changer. But once that 4.5-hour window slams shut, the risks of giving the drug, especially the risk of causing a fatal bleed in the already damaged tissue, totally outweigh the benefits. So visualize the ticking clock. You've got that strict 4.5-hour golden window for TPA right out the gate. But thankfully, modern medicine is amazing, and we now have mechanical thrombectomy, which can actually extend that intervention timeline up to 24 hours. This is where a specialist snakes a catheter right up into the brain to physically grab and pull the clot out. It can literally save highly selected patients with large vessel occlusions, hugely expanding our window to rescue that brain tissue. But circling back to TPA, we definitely cannot give this powerful drug blindly. You must screen fast for some very strict contraindications. First off, if the CT shows a hemorrhagic stroke, TPA is absolutely forbidden. Done. You also can't give it if the patient has had recent major surgery, severe uncontrolled hypertension, or known bleeding disorder. If you miss these, you're risking catastrophic internal bleeding, and we definitely don't want that. And even after the clot is dealt with, the fight is far from over. We've got to meticulously manage the patient's supportive care. That means optimizing oxygen, carefully controlling blood pressure so we keep the brain perfused without blowing out damaged vessels, and getting them on antiplatelets like aspirin. All the while, we're watching them like a hawk for deadly complications. That infarcted tissue can swell up, causing cerebral edema, or it can just spontaneously start bleeding, what we call hemorrhagic transformation. Let's wrap it up with Section 6, High-Yield Rapid Review. All right, if you take away literally nothing else from this explainer today, you've got to memorize these 5 high-yield one-liners. Ready? Most common stroke is ischemic. Most affected artery is the MCA. Mandatory first investigation is a non-contrast CT scan. Your golden window for TPA is 4.5 hours, and the primary driver of those deep lacunar strokes is chronic hypertension. This chronological flow is the exact mental sequence every single medical professional needs dialed in. Patient arrives with stroke symptoms. Step 1, CT first. Step 2, check that scan to definitively rule out a bleed. Step 3, if there's zero blood, you're under that 4.5-hour mark, and there are no contraindications, you give the TPA. It's a strict, absolutely life-saving algorithm. Ischemic stroke really is the ultimate test of medical preparation against time. You've got the knowledge now. You can recognize the signs, understand the anatomy, and confidently follow the emergency protocols. So, I'll leave you with this thought. When the clock starts ticking and millions of neurons are dying every single minute, will you remember this exact sequence to step up and save a life? Take these golden rules, stay structured out there, and never forget, time is brain.